Thank you, Dr. Sushmita and the esteemed panel for having me here. I'm talking about optimizing cataract surgery in corneal ectasia. I think all of us who are dealing with cataract surgery with keratoconus are dealing with these three categories of patient where you're doing cataract surgery alone, or you're doing a combined surgery, or you've done keratoplasty at some point when the patient is younger and now you're planning the cataract surgery. So I'm just going to talk very briefly about the nuances in each of that. And when you're dealing with doing cataract surgery alone, so obviously it's going to be in a non-progressive ectasia. So when it's naturally non-progressive is when it's an older patient, probably in his 50s or 40s, where he's not progressing, or in the younger patient where you already like addressed his ectasia and you've made sure that you've treated the ectasia and the progression of it. Or if it's a happy contact lens user, where he's got advanced ectasia but in the older patient, but he doesn't want to address the cornea, in the sense doesn't want a keratoplasty. He's a happy contact lens user and he's not willing, or logistically you don't want to do that. And if it's an advanced keratoconus, then you can still just go ahead with cataract surgery and rehabilitate him with the contact lens. Now toric oil, it's a big bugbear whether we use don't use. So obviously if the astigmatism is more regular, then you use that. How do you decide that? Look at the topography, look at the holiday AKI report. Even if you don't have any fancy equipment, you just look at your basic topography. That itself will give you an idea. If the most of the cone is in the central area, if it's a central cone, then you can go ahead with using a toric IOL. But if it's an absolutely decentered cone, then those are the cases where you're not going to get good results with the toric IOL. Then the EKR report, if the reading is like this, I think that's fairly acceptable rather than something like this. Now, when you do it after 6 months minimum, you need to wait. After cross-linking, you can see most of the time that stabilizes, though of course at 11 months, it's obviously ideal. This is a 16-year-old girl with chronic allergic conjunctivitis, with progressive K-conus, with a posterior subcapsular cataract. So we had to address all of that, treat her allergy, then treat the cross-linking. Both the eyes cross-linking was done, and 6 months after that, we planned the toric IOL. Now, these are different cases where I've used toric IOL. You can go ahead with using, image-guided system or manual marking, whatever you may have. So that I've marked it directly with a pen there. But you know what? Nowadays, what I do is I use a Sinsky hook and I use that for marking because it's a much more fine and marking. Here on the left-hand side, you can see at the end of surgery, sometimes I feel, especially in patients with a deeper AC, if you're very forceful during the hydration, you can see that IOL has just rotated. So be a little mindful of that in the toric IOL. Make sure you're being careful about that. And in very high myopes along with ectasia, you should go ahead and probably put in a CTR, is what the understanding is. And if you're doing a keratoplasty first, then all sutures have to be out if when you're planning a cataract surgery, and 3 months after suture removal. So that we were looking at about a year to year and a half in after keratoplasty, never before that. Toric IOL is definitely useful. PTKs can be done. This was a case where I planned to do a toric IOL because it was, though a very high astigmatism patient, was it was irregular. Make sure you're protecting the endothelium. That would be the only mantra I would say. And also protecting the epithelium, because in these cases, as we know that sometimes epithelial defects, if you land up with that, they're also a little bit more difficult to heal versus say a normal cornea. So in these cases, use a soft shell technique, use trypan blue if you feel like the there's this cataract is dense. Here, as you can see, protecting the epithelium and the endothelium with a lot of viscoelastic, and then you can go ahead with placing your toric IOL and get a great result. Now, this is how it looks when you're doing suture removal. You're not removing all sutures, and you keep calling the patient back. Eventually, patient does the well and gets 6/6 best corrected or unaided vision. Now, this is a patient where actually, if you see, it's a graft, and he had almost like a hydrops in his graft and edema. Operated at Moorfields for this graft, and other eye also he has advanced keratoconus and not getting the keratoconus readings. So even though ideally this was an ideal candidate for say a triple surgery, I still decided to not, because I wasn't getting any kind of keratometry readings. So I did a phase surgery, like sequential surgery, did all the did a graft, got all sutures out, and then planned a toric IOL. And this is a, I think, 6/9 unaided patient. He's doing really well. Again, if you're doing DALC also after surgery, then get all the sutures out, and then eventually at the end of it is when you're going to plan surgery, once all the sutures out. And DALC probably, I think, 6 months after that is good enough. You can get all the sutures out and then plan your cataract surgery. If you're combining, obviously, if it's very advanced ectasia, patient cannot have two procedures. then you do that. Ideally pick PK with DALC, because rather than DALC, because when DALC is a high chances of perforation, you can go up till the anterior stroma and still complete your DALC. Coming to PK triple, the problems are with, of course, inaccurate IOL calculations, and very difficult to get a rhexis. So way to beat that is that make sure you're doing a closed chamber surgery. This is a 55-year-old male with ectasia and scarring. And so what you do is, in these cases, you are first doing a closed chamber phaco, and then you, once at the end of surgery, you just go ahead and, insert, like do a regular keratoplasty. So it's always better. So yeah, so that's the end of my surgery talk. Thank you so much.
No, thank you. Are there any questions or comments? Because Dr. Rao has to go to another session. Are there any questions? Okay, thank you.
Thank you.